Thank you for the invitation. So I will talk to you about the use of the Domino connector for PSO and VCR reduction techniques. Fixed sagittal and coronal malalignment in spinal deformities has become a frequent spinal condition during the past 2 decades. And surgical management with use of 3-column osteotomies, such as the pedicle subtraction osteotomy or the vertebral column resection, has proven to be very efficient in improving the patients both clinically and radiographically, despite the complication that may occur with such procedures. So these procedures are challenging and risky as they contain different steps that should be correctly performed. And one of these steps is the reduction of or closure of the PSO VCR site, which will lead to the final outcome. So in the case of the PSO, you need to cut the vertebra and to close it posteriorly in order to have the correction. In case of VCR, after removing the ribs, you may remove 1 level or 2 levels of vertebrae and reach the correction by doing a posterior compression. So there has been several publications about how to close technically and specifically the PSO sites, such as using in situ bending or using a kind of central hook rod construct. A study mentioned the use of sublaminar bands or a kind of reduction plier in order to close the level above and use the level above and below to close the osteotomy, and what was called the outrigger technique by Gupta by using kind of short rods on the sides of the osteotomy. Regarding the VCR, also different technical papers have been published, such as using a hinge in order to facilitate the reduction. Also, the use of sublaminar bands was mentioned. The one that mentioned the dominoes was the one by Dr. Kibesh, actually, that I found here, published in JBJS, mentioning the technique he told us about just before, the M-block fixation and reduction, which actually is, for me, the most interesting because it's similar to what I do. And this very recent paper from October by Sucado about a uniplanar clamp hinge system for the correction of VCR, but still it's on a sawbone model. So the use of the domino is interesting because the domino is a very powerful tool. It enables 3-column osteotomies closure by involving directly several pedicles screws simultaneously, but without applying a direct compression or rotation on them. It helps achieving also an asymmetrical correction when needed in case of combined sagittal and coronal deformity. And we published 2 papers about the use of the domino in the lumbar spine and also in the thoracic spine in the European Spine Journal. So it consists of using 2 parallel rods connected by a side-to-side domino connector on one side in order to achieve gradual and controlled compression at the osteotomy site. So the complete technique usually combines some cantilevering and some compression. There may be 2 variations of rod cantilevering. In case of mild to moderate deformity, we can do a translation, so just 1 block cantilevering by connecting the 2 rods, and after that compression, or to do a double block cantilevering by pushing on the 2 rods at the same time and connecting them with the domino. So this may apply either for the PSO or the VCR. This is an example on the left side for the 1 block cantilever and compression, and on the right side for the 2 blocks. Here just a short video. Once it's inside, we do the compression, and so we translate the proximal block and the distal block inside the domino by liberating one of the domino set screws, and so 1 rod will slide, as you can see here also on the right side. So it's very powerful for the closure. And as you can see on these intra-op pictures, the remaining gap between the 2 vertebrae, the one that got osteotomized and the one above, get completely closed after the use of the domino. And of course, we did not overload or overstress the screws just above and below. And so in case of combined coronal and sagittal deformity, we may also achieve an asymmetrical reduction, and usually the principle is to put the domino on the convex side of the deformity, not on the concave side, in order to achieve sagittal and coronal correction of the malalignment. So I will go over some cases in order to illustrate what I'm talking about. So this is a 15-year-old girl with a congenital kyphoscoliosis. As you can see, we cannot see it properly on the X-ray, but there is a lumbar kyphosis because of the big hemivertebra. And so the hemivertebra was resected, and as you can see, because the convexity is on the left side, the domino was placed on the left side in order to correct the coronal deformity and also the sagittal deformity, achieving a partial correction, because actually she had a fusion here, so our intention was not to complete the correction, to achieve a complete correction, because we didn't want to have a coronal malalignment, and the lumbar lordosis also was restored. This is a young patient in his 30s with ankylosing spondylitis. As you can see, he has his gaze is going down. He's been walking like that for several years. Lumbar lordosis is around 4 degrees, so his mismatch is around 40. So as you can see, he's straight on the coronal X-ray. And so in this case, the domino may be inserted either on the right side or on the left side at your convenience. And after the closure of the osteotomy, you can achieve a very satisfactory triangular shape of the vertebra, achieving a satisfactory alignment after the surgery with a lumbar lordosis of 46 degrees, and most importantly, actually, a normal horizontal gaze for the patient. This is a patient who is 14 years old, who has a kind of rare syndrome. He was previously operated with the use of Vector device. He had multiple surgeries actually in the past. And so as you can see, he has a very severe thoracolumbar kyphosis with also an onset of coronal malalignment to the left side. And so in this case, the surgery was to remove actually the apical vertebra in order to try to correct as much as possible given the stiffness of his spine, because there is also fusion in the proximal levels. And as you can see, he's going to the left, but when you see the coronal 3D scan, the convexity is on the left side. So in this case, of course, we need a temporary rod in such cases in order to avoid destabilizing the spine. And after the resection has been done, the domino was inserted on the left side because the convexity was on the left side, and progressive compression and reduction was able to achieve a satisfactory correction in the coronal plane and also in the sagittal plane with a bone-on-bone contact, actually, in this case, which was tolerated by the patient, and also a satisfactory clinical outcome. We used multiple rod constructs all around the area in order to try to protect as much as possible, because in these syndromic patients, sometimes the fusion rate may be also long and difficult to achieve. This is a lady in her 40s who's been complaining of low back pain for several years and also difficulties in walking. She has this kind of wedge vertebra with anterior aplasia in 2 levels. And so in this case, a pedicle subtraction osteotomy at T12 was done. As you can see, she has a convexity of the deformity on the right side. And so in this case, the domino was inserted on the right side in order to compress on this side and achieve correction of both coronal deformity and sagittal deformity. And as you can see, the compensatory lumbar hyperlordosis was reduced after the correction of the apical deformity, and this is a CT scan with fusion after a few months of the surgery. This is another male, also in his 40s, with a butterfly vertebra. But in this case, actually, this patient had neurological symptoms, pyramidal syndrome. He had myelomalacia at the level of the deformity, and we didn't want to shorten a lot in order to avoid any kind of neurological compromise. And in this case, a cage was inserted. The cage was inserted on the left side, and the domino was inserted on the right side to achieve compression here and distraction on the left side in order to correct the coronal and the sagittal malalignment at the same time. This is to show just the restoration also of the thoracic kyphosis. Usually the hyperlordosis decreases and the flattening of the thoracic spine improve with thoracic kyphosis. This is a young girl at the age of 10 or 11. She had a previous surgery with hemivertebral resections. She had situs inversus, dextrocardia, with multiple congenital issues. And so she developed progressively a severe kyphosis with the onset of coronal malalignment, very severe thoracolumbar kyphosis, and very severe lumbar lordosis of 95 degrees. And so in this case also she had some kind of neurological symptoms, so a PSO was done, a modified PSO was done at the apex of the deformity, and the domino was placed on the right side because, as you can see here, the convexity is on the right side. So in order to shorten the right side, the domino was placed at that area, despite the fact that she's going here on the right side. And so it enabled achieving a satisfactory coronal and also sagittal alignment, even if the thoracolumbar kyphosis remained relatively high, relatively speaking, but given how the deformity was initially, it enabled her to have a more normal morphotype and normal walking. This is a patient in his 30s with a kind of block or two blocked vertebra, two wedged vertebra here at T11 and T10, reaching the middle of the vertebral body of T12. He didn't have any kind of neurological symptoms, but of course important low back pain because of the compensatory hyperlordosis. So in this case, removing the two apical vertebrae was done, and as you can see here, there is a major osteophyte anteriorly, and so the strategy was to try to open this osteophyte in order to achieve a closing opening technique, which actually would shorten less the cord when compared to removing a vertebra that would go completely to the anterior longitudinal ligament. And so after the correction, of course in this case, no coronal malalignment, so the domino can be inserted either on the right side or on the left side. This is the correction after the resection, and as you can see here, the anterior osteophyte completely opened, similarly to what we published before about closing opening wedge osteotomy for the PSO. And so usually in these cases, the shortening of the spinal cord may be more tolerated. What was interesting in this case with the domino is that a translation happened. Actually, when the osteophyte broke, there was a very crack sound. So there was a translation of the spine. And so the domino, as you can see here, we cannot see it on the AP view because using the domino, I rotated it in order to put it in a sagittal plane, which actually corrected the translation. So in this case, the domino was helpful to correct the translation that may sometime occur in deformity correction with three-column osteotomies. This is the last case, also a syndromic patient that was operated multiple times with this fixation technique with proximal distal screws that broke. He ended up having a severe deformity coronally and sagittally, and the problem is the rod progressively migrated inside the canal. He didn't have any kind of neurological symptoms. We performed a combination of VCR and PSO in this case. He had dural ectasia, and so by actually removing the previous construct and performing both 3-column osteotomies, compression with the domino on the left side this time achieved satisfactory coronal and sagittal malalignment. So in conclusion, the correct closure of the 3-column osteotomy site should lead to satisfactory correction with either a bone-on-bone contact or a strong cage stability. Different techniques have been described, but many of them may overstress the hardware. So the use of the domino as a closure tool enables distribution of correctional forces across multiple screws simultaneously and increases the power of compression at the 3-column osteotomy site. Thank you.